Hello, let's learn about diagnostic tests for infectious diseases, the principal advantages and limitations. Diagnosis have three phases: pre-analytical phase, and post-analytical phase. Pre-analytical phase consists of examination and provisional diagnosis. It is related to collection, storage, and transport of samples. While analytical phase is related to microscopic examination, culture techniques, molecular analysis, serology, and biochemical tests. While post-analytical phase is related to reporting of identical microorganisms and antibiotic sensitivity. So far, what we have learned about specimen selection is a key component for diagnostic stewardship. Specimens should be selected based on clinical relevance. They should be representative of the disease process and should be collected before administration of antimicrobials. The specimen amount and the rapidity of the transport to the lab influences the test results. Our objective in this session will be to understand the diagnostic accuracy, overview of diagnostic tests for infectious diseases, and to understand applications and limitations of microscopy and cultures. Now let us learn about what are the measures of diagnostic accuracy of a test. This includes sensitivity, specificity, positive predictive value, negative predictive value, likelihood ratios, whether positive or negative, receiver operating characteristics curves, that is ROC curves. Now, what is my sensitivity? Sensitivity is the percentage of true positive tests among diseased. It is the ability of a test to yield a positive result for a subject that has that disease. It is a ratio of true positives upon true positives plus false negatives, that is all deceased. The limitation of sensitivity is that it has false positives is an issue. Then we have specificity. It is a percentage of true negatives among who do not have a disease. It is the ability of the test to obtain normal range or negative results for a person who does not have a disease. Specificity is a ratio of true negatives upon true negatives plus false positive, that is all non-diseased. Sensitivity and specificity are inversely related. As sensitivity increases, specificity tends to decrease and vice versa. Now let us learn about predictive value of a test. Positive predictive values determine among all positive tests how many are true positives. Negative predictive value determines among all negative tests how many are true negatives. Positive predictive value is the ratio of true positives upon all tested positives, that is sum of true positives plus false positives. And negative predictive value is the ratio of true negatives upon all tested negatives, that is the sum of true negatives plus false negatives. So predictive value is impacted by disease prevalence. Let us learn about sample collection. We have seen sensitivity, specificity, and predictive value. Let us now learn about sample collection. Collections from actual site with minimum contamination is a key. There should be an optimum time of collection. Sufficient quantity of specimens should be collected. Obtain the sample before starting antibiotic. Proper labeling of the container needs to be done. Appropriate collection device needs to be used. So all are the factors affecting specimen collection and transport. What are the type of specimen that we process for diagnosis of infectious disease? One is a blood specimen, then respiratory tract culture, urine culture, wound and soft tissue culture, fecal culture, then anaerobic pathogen and fungal culture. Blood specimen. Regarding blood specimen, one blood culture usually consists of a blood from single vein pincher, inoculated into two separate bottles, one aerobic and one anaerobic. The optimal blood to broth ratio should be 1:5 to 1:10. Sodium polyethylene sulfonate, that is about 0.025 to 0.05%, is added as an anticoagulant, an antiphagocytic agent. Lower respiratory tract culture, expectorant is a sputum collection having 3 steps: clear your mouth, breathe in and out 3 times, give sputum sample. The induced sputum is used for pneumocystis carinii and mycobacterium tuberculosis testing. Patient mouth is rinsed thoroughly with sterile water or saline, and using an ultrasound nebulizer, patient is made to inhale approximately 20 to 30 ml of 30% NaCl. Status of respiratory tract culture specimen. Regarding tracheostomy and endotracheal aspirate, the specimen is aspirated into a sterile sputum trap or leak-proof cup. Tracheostomy aspirate should not be cultured unless clinical pneumonia is present. Tracheostomy is followed by colonization within 24 hours of insertion, and results may not correlate with disease. Hence, in the sample should be cultured immediately. Bronchoscopy specimens, it includes ball samples, bronchial washings, transbronchial biopsy specimens. Culture ball samples quantitatively or semi-quantitatively for bacterial pathogens. Let us now learn about urine culture. Urine culture is mostly the sample cut is a clean, watered, midstream urine culture. In females, the labia are held apart, vulva is washed from front to back. In circumcision males, no preparation is required. In uncircumcised males, foreskin is retracted, glass penis is washed. Patient is asked to collect voided urine directly into a disposable leak-proof container, inserting the patient to not halt and restart the urine stream for midstream collection, but preferably move the container into the part of already voiding urine. Urine obtained from catheter bag should not be sent. Using a needle and syringe, urine is collected through catheter, port, and after cleaning with alcohol. Early modern specimens should be obtained whenever possible. Regarding wound and soft tissue culture, skin or mucosal surfaces should be cleansed. Closed wounds and aspirates disinfected with 22% fluorescein and 70% alcohol, followed by iodine solution. 1% tincture iodine or 10% protein iodine is used. Open wounds should be debrided and thoroughly rinsed with sterile saline prior to collection. Viable inferior tissue should be sampled rather than superficial debris. Swab collection should be avoided if aspirates or biopsy samples can be obtained. There are a dizzying array of highly complex tests. Now, what do I do now? There are many tests. What should we do? Now, let us understand the purpose of a diagnostic test. It is either for screening of a test, risk assessment, diagnosis, that is to distinguish infection from non-infective etiology, then diagnose sepsis, identify the pathogen, make treatment decisions, prognosis, epidemiological purposes, and research. Tools for diagnosis of infectious diseases. It includes direct methods like microscopy, then culture techniques, that is isolation of culture media, identification sensor testing, then all culture techniques like serology, that is detection of antigen antibody, detection of specific gene, that is molecular tests. Then we have indirect method like serology, IgG, IgM testings. What is in microscopy? One of the most common available tests, but underplayed test. Rapid Dunley microscopy can help initiate the empirical therapy in minutes. Moderate sensitivity but specific. Sensitivity depends upon the time and number of microorganisms present. It depends upon the technique of specimen collection and stage of the disease. For microscopy, we use either wet mount or stains. In wet mount, in mostly the urine sample, we see the demonstration of bacteria and neutrophils. In stool, we see the darting motility for ubiquitary and demonstration of parasite, ova, cyst, and larvae. Then skin or hair scrapings is done by 10% KOH and observed for fungal elements. Then vaginal secretions we see for trichomonas. For ball we see for the Stangurus larvae. And CSF we see for the cryptococcus. That's all in microscopy it can help it a very rapid immediate diagnosis test that can be used for diagnosis of the infections. Microscopy the gram stain then is done apart from the wet mount. In gram stain we do the demonstration of bacteria or pus cells from normally sterile body sites. Indirect identification is done after growth in culture. Then for microscopy or the gram stain to be positive, it requires at least 10 to 4 bacteria per ml of specimen. The difficulty of discriminating between normal flora and pathogen, that's the issue with the microscopy. The various stains employed are acid fast stain, modified acid fast stain, fluorescence staining, and immunofluorescence staining. Direct immunofluorescence is used for pneumocystis and legionella, while indirect is used for syphilis. Fluorescence staining includes acridine orange for bacterium fungi, then Oraman rhodaman and Oraman O for mycobacteria, then calcofluor white stain for fungi, especially dermatophytes. Modified acid fast stain is used for Cryptosporidium, Microsporidia, Cyclospora, Isospora, Baldalmuncolia, where acid fast stain is commonly used for mycobacterial tuberculosis. There is a dark field microscopy, which is used for spirochetes in genital lesions, and Borrelia leptospira in blood. Then we have Elterman microscopy, which is used for detecting viral pathogens. What are the advantages and limitations of microscopy? The advantage is that it is easily available, easy to perform, and inexpensive. Allows judging of specimen quality, presumed to identification of many etiologic agents. It's like screening of the specimens in microscopy is helpful, evaluating the type of inflammatory response. providing guidance to the lab, helps in selection of empirical therapy. It is a high specificity for certain organisms. However, the limitation is that it requires technical expertise. Sensitivity is low. It requires 10 to 4 to 10 to 5 organisms per ml. Doesn't allow species identifications. That's the issue with microscopy. Then we have culture, which is followed by antimicrobial sensitive testing. Culture, we have choice of culture method or media. Then clinical presentation and based on microscopy and suspect pathogen. We have growth, identification, sensitive testings. Culture is the backbone of methods of culture, conventional methods and automated methods. Conventional is the in-house prepared blood culture bottles are used or commercially procured. Now, automated methods we have bacterial, bacteric, and versatile. The testing can be either qualitative, where there is a presence or absence of growth, or semi-qualitative, where we count the organ colonies in terms of colony forming units per ml, or it may be quantitative, where an absolute number is provided. Then in conventional cultures, we have blood cultures, either for 48 hours provision reports are given, or 5 days final report is dispatched. Mycobacterium 4 to 6 weeks. It takes 4 to 6 weeks for isolation, and it's 3 to 4 weeks for identification and sensitive testings. While for fungi, it takes 2 weeks for identification and sensitivity. For dermatophytes, it is 2 to 4 weeks for identification and sensitivity. Other samples like stool and sputum and CSF, it took us 24 hours for isolation and 24 hours for sensitive testings. The early pathogen identification is essential. We have seen that it takes days and weeks, but for every hour of delay in initiation of the effective empirical therapy, following one set of septic shock, patient survival decreases by 7.6%. Only 85% survival rate is there in sepsis. 8% patient survival rate decreases. There is a delay in detection of diagnosis. So the principle is hit hard and hit hardly. Empirical and broad spectrum therapy needs to be initiated. Delay in targeted therapy will affect the patient management. 50% of bloodstream infection and up to 70% of fungi may receive incorrect therapy during empirical treatment before culture results are available. There is a need for automation to reduce mean time for pathogen isolation by continuous monitoring of bacterial growth. We have blood culture systems like Bactec, Bactilert, microbial culture systems like Midget 960, which can be used for early diagnosis of infections. Then to reduce mean identification time for organism isolation and susceptibility results. For this, we have Bitech, Phoenix, Microscan, Walkaway, and Malditoff. Now, what is the workflow? Is automation? Is automated culture systems available? Culture bottles flag positive, and then we have the flagged positive bottles are used for gram stain. Either it is the sensitization done on a rapid method, which takes about 12 hours for the results, or it is subcultures and then identified and sensitization done, which will take 4 plus 12 hours. So what's the difference between conventional and automated? Conventional is less sensitive. It is a slower time for to positive. It increases chances of contamination. It has more false chances of false positive chances. It is cheaper. It is daily once or twice checking for growth is required. It is tedious. No maintenance is required. No continuous supply of electricity is required. Good for smaller labs and workloads. While automated is more sensitivity, faster time for positive, and less chances of contamination, lesser false positive. However, it is expensive. No need to check manually also. But it is simple. It has an expensive maintenance. Continuous electricity supply is required, and expandable units is required. It's good for good larger labs with good workload. Now, assessing culture, what are the advantages and disadvantages? Advantages is it assess the living microbes, is able to recognize viable cells, easy to quantitate the cells in the sample, and has a high sensitivity. The disadvantage is the risk of contamination, high skill level is required, time and resources are intensive, and relies on phenotypic biochemical characterization.